would like to thank Dr. Mahesh for including me in this very interesting instructional course. So I have a little bit of leeway in the way I present my talk because it's on what is difficult. So it need not go in a story as a sequence, but I'll try to make it into a story as a sequence, but it may be going haphazardly and I may end abruptly. That doesn't matter because I'm only trying to talk about what is difficult and not what is easy, at least from my perspective. So I think when we talk about a traumatic retinal detachment, we're talking about the issues in the eye that influence our decision-making process as to how we are going to approach the treatment. So these could be anatomical issues right at the time of injury and immediately after the injury. And these are the amount of corneal damage, the amount of integrity of the eyeball, the presence of choroidal detachment, which is serous or hemorrhagic or a combination, mixture of the vitreous with the blood, disruption of the anti-segment, how bad is it, the iris is gone or iris is traumatized, then retinal architecture, how badly it is damaged, and then injury to the sensitive structures such as optic nerve and the macula. But as a vitreoretinal surgeon, we are also interested in what are the anatomical issues when we decide to interfere. It's not always that the retinal surgeon comes into play at the time of repairing the injured eyeball, but we need to come into play when we want to restore the eye to its integrity from the retinal and functional point of view. And that is where I would call it as a definitive surgery, where you want to remove all optical impediments and reattach the retina so that the patient can see. So there again, the clarity of cornea should be judged so that we need to decide whether you want to do a combined surgery with a keratoplasty or just do a vitreous surgery. Again, we should understand that a mild haze in the cornea, which looks pretty bad preoperatively, on the table tends to clear very fast. Once you remove the inflammatory fibrin and restore the eye to the normal intraocular pressure, the cornea actually becomes clear enough to be able to manage without removing the cornea itself and do with our regular light pipe, etc. Lens status is important for you to again decide whether you are or not going to remove the lens and whether you are not going to put an intraocular lens at the same time. Damage to the iris and ciliary body will cover a little later, and again you need to judge where the wound is and where the retina is incarcerated, etc., so that you can decide where to make the sclerotomies, avoiding the areas of incarceration. The systemic issues that complicate the surgery are the presence of associated neurological or neurosurgical trauma, wherein the ocular management can become secondary and sometimes can be actually missed for a very long time, and the patient who has had actually neurosurgical trauma, people may discover that there is ocular trauma also with it much later. But where there is a good interaction between neurosurgeons and ophthalmologists, you can always combine the ocular repair along with the neurosurgical intervention. The retinal detachment repair occurs maybe about 10 days, 15 days later. That is when you need to see whether the patient is fit to go through another GA or not, considering the neurosurgical trauma. And at this point of time, you always find that the ocular trauma probably was not properly managed, not even detected, because the patient was in a coma. Our initial globe restoration was not adequate. A very slipshod repair of the eyelids was done, and a conjunctival repair was done, but not a good explorative repair of the scleral wound. And a definitive surgery could have been delayed for such a long time that there is so much intraocular fibrosis that distorts the retina and makes your surgery extremely difficult. There could also be an orbital and adnexal trauma, which could also make the eyelid cover very difficult. That is, you do a good job of the eyeball, but you're not able to give a good eyelid cover to it. That's where your oculoplastic surgeon's help is important. There are other issues. There could be bilateral injuries, which are not uncommon. And often this involves younger age group, and there are emotional issues and very high expectations from the patient side. There are obviously medical legal issues as well. So it's very important that we put it in the correct perspective without upsetting them too much, but making our point clear that we do not know the outcome finally, and multiple surgeries may be required, at the end of which we may still end up with no proper vision. There are issues related to a closed globe trauma with a detachment, wherein the detachments are more chronic in nature, related to the retinal dialysis in the milieu of a vitreous which is not as yet detached, which is the reason why you get late onset detachment, not early onset. Having said that, I can share with you two cases where the patient had an injury, and within hours patient came to us with a dialysis, what looked like a dialysis, a tear, and a massive detachment, a huge bullous detachment. So the first impression is that this is a giant retinal tear with a detachment. But when I looked at it very carefully, I was not convinced that the vitreous is detached. And what I did was actually indented the eye at that point in the outpatient clinic, and to my surprise, actually the vitreous blob came into the vitreous cavity and the retina went back. So what happened due to the violence of the trauma, the vitreous is propelled into the subretinal space by the injury, the vitreous gel, not liquid vitreous. And hence what you have is an acute detachment of retina because the vitreous gel has gone in. Even just keeping the patient positioned or giving him a rest for a day or two, the vitreous gel actually migrates back into the vitreous cavity and the retina goes back, allowing you to just do a laser without any surgery because the retina is not detached with fluid underneath. But dialysis, as I said, can be missed in the backdrop of a chorioretinal atrophy caused by the trauma. And you find very often that these are patients where the ophthalmologist has seen but has not detected the dialysis, which is hidden in the backdrop of a chorioretinal atrophy. What all it was needed was just laser photocoagulation, but by missing it, you end up in having a detachment much later. And very often trauma could be forgotten and a detachment due to dialysis may not be appropriated to a trauma. And you should also not forget that these are eyes which there is angle recession glaucoma, very often masked or camouflaged because of the presence of a detached retina. And the day you reattach the retina, the pressure shoots up because now the angle closure comes into play. Or if a patient comes to you with a detached retina and a glaucoma already existing, the management becomes difficult. You know 100% sure that the pressures will go up even further once you reattach the retina. So it makes sense to do a glaucoma surgery as well, along with a retinal reattachment surgery. With an open globe injury, we are dealing with a different set of complications. The need to sacrifice the lens, the retinal incarceration anteriorly in the anterior wound, a posterior incarceration of the retina at the site of the globe perforation, early and very severe PVR because of admixture of the vitreous with blood and the cutting of the choroid and the sclera. Subretinal blood, which could be variable in its extent, and subretinal gliosis, which could be as thin bands all the way to thick sheets which cover the entire subretinal surface. And these thick sheets can actually be not obvious until you actually remove the preretinal membrane. Then you find the retina is very stiff, not because of intraretinal gliosis, but there is actually a subretinal sheet of membrane. Definitive surgery usually is planned about 7 to 15 days after the primary repair. We tend to give steroids preoperatively to make the eye quiet, the inflammation less, choroid less suffused, less edematous, and hence the eye probably can have less risk of recurrent PVR after surgery. The status of the retina is very often not evident preoperatively, and you make your decisions intraoperatively based upon each step follows the other. So you don't tell the patient whether the retina is detached or not. You're going to decide on the table. The first step, of course, is to assess the corneal clarity and the need for a combined PK. If it is not required, you go ahead. You may like to play an encerclage in some cases, but where you think you may end up with a 360-degree retinectomy, there's absolutely no need for you to unnecessarily extend the pre-surgical steps by placing an encerclage. You drain the suprachoroidal blood first so that your infusion cannula can be placed properly. And the amount of drainage would depend upon your assessment preoperatively as to where the suprachoroidal blood is maximal. And you form the anterior chamber, form the vitreous cavity by injecting saline through the anterior chamber. Because very often the lens is already traumatized, it's very easy for the fluid to be injected through the limbus. And once enough blood is removed, then you place the infusion cannula, assuring yourself of its location. You should understand that despite draining the suprachoroidal blood and suprachoroidal fluid, still the choroid is probably partly detached and the infusion cannula tends to still slip into suprachoroidal space. So there is also difficulty in introducing instruments, not just the infusion cannula but other instruments as well. And the instruments can actually push the ciliary body ahead of them, and you need to repeatedly push them back into the intravitreous space across the ciliary body. There is anterior loop traction which is occurring in the retinal periphery because the retina is pulled anteriorly into a corneoscleral wound. And this again makes your instruments go through the retina into subretinal space. And very often a retinectomy is required even at the beginning of the surgery to enable a proper vitreous surgery. This is just a video which shows the retinal, the infusion cannula not being able to enter the vitreous cavity, wherein you enter the MVR blade at the opposite quadrant and then cut over the indentation caused by the infusion cannula. And once the infusion cannula is inside, you can proceed with surgery normally. But again, having said that, During surgery, you must be conscious of the fact that this can tilt on either side, and the tilt can allow the tip to slip again into suprachoroidal space. So you should make sure that the cannula is never tilted. And in the era of the 23 gauge or 25 gauge cannulas, you don't fix the cannula. The cannula can slowly slip out of the eyeball, and then suddenly you'll find a suprachoroidal detachment taking place. The choice of sclerotomy site is important. You avoid the scleral scars for obvious reasons, because the retina could actually be incarcerated in those wounds. You avoid previous sclerotomy sites because they can enlarge and merge into one large hole which can keep on leaking, keeping profuse hypotony. And a 23 gauge or 25 gauge is obviously better than 20 gauge because these trocar cannula systems don't allow the sclera to enlarge. You can choose odd locations instead of the usual traditional locations in these cases because of obvious reasons. You can have a cannula placed inferior-nasally or even at 12 o'clock, and even all three sclerotomies placed superiorly so that you can manage the case much better. The vitrectomy is thorough, and a vitreous shaving is a must in all the cases of traumatic retinal detachments. And this vitreous shaving need not necessarily mean a sacrifice of the lens, has been shown elegantly by Dr. Mahesh yesterday in one of his presentations of phakic peripheral vitreous debulking, where you can nicely indent the eye and do a peripheral vitreous shaving without needing to sacrifice the lens in all cases. But where necessary, don't hesitate to sacrifice the lens. Our aims are much more than just retaining the lens in these eyes. There is a special attention required for the vitreous in the wound. It has to be very carefully, deliberately observed and removed. And you should also observe that the vitreous can be adherent to the posterior surface of the iris without being in the wound, and that causes as much traction on the peripheral retina as even a vitreous in the wound. And this also has to be peeled away from the posterior surface of the iris. This is because of the violence of the trauma. The vitreous is propelled against the iris and it gets stuck to the iris surface. You should manage the uveal tissue by suturing a cyclodialysis cleft at the same time, repair the iridodialysis at the same time, and reconstructing the pupil. Reconstructing the pupil goes a long way, especially in silicone oil filled eyes, where you don't want the oil to migrate into the AC easily. Now, this is a case of cyclodialysis cleft, which is being repaired at the same time as a vitreoretinal surgery. And the cyclodialysis cleft is actually extending from here all the way up to here. And we are using just a mechanical kind of suture technique because you're already inside the eye, vitreous is already removed. It's not difficult to just suture the cyclodialysis cleft to the scleral spur or scleral wall. Roughly about 1 to 1.5 millimeters from the limbus, you make the scleral cut. It's a groove actually I made. And you come out through the limbus and again reverse the needle and go back in through the same track, and then use a 27 gauge needle to take it out next to the point of entry. This is where you can actually see the cyclodialysis. You see, the ciliary body is actually here. And hence, I'm not able to penetrate with the needle, so I have to use it to support the ciliary body while you penetrate the needle actually through the fine needle of the 10-0 prolene. And then you bring it out and tighten it across. So the same thing can be done in multiple locations depending upon the extent of cyclodialysis. So reattaching the ciliary body at the same time is very crucial. Number one, it makes your further surgery easy because your instruments can go through the ciliary body without pushing it in front of them throughout the surgical step. And it also makes it easy for you for the fact that the patient may not have cyclodialysis cleft related hypotony postoperatively. This is the second step, second suture which is being placed to suture the cyclodialysis cleft. So very often as vitreoretinal surgeons, you're concentrating on the posterior segment and you ignore the fact that this is equally important. Then cleaning the retina, differentiating between altered blood and retina is very important, and it's not easy, mind you, especially in the milieu of a hazy media. You can always mistake an altered blood as retina and vice versa. You may spend a lot of time trying to carefully dissect a altered blood and actually go through an altered retina, not knowing that you're actually cutting through the retina. So you cleaning the retina, 23 gauge instruments are better than 20 gauge. Bimanual surgeries may be needed for extensive preretinal membrane dissection as well as for removal of subretinal bands. As I said, don't hesitate to make large peripheral retinotomies because what is clinically visible as a fine band actually is thick sheet with relative condensation locally which is making it visible. So once you remove the band, you can actually see it's extending as a big sheet subretinally, and removing all the sheets is important in fixing the retina. The mantra is clean, clean, and clean. Retinotomies are required for removal of subretinal bands and for reattaching the retina. And as you can see in this case, the way the vitreous is going posteriorly tells you where the retina is incarcerated. I'll jump. a little bit. So this is the peripheral base excision, and the retinectomy being done all along the all around the retinal incarceration site. So difficulty due to compromised visualization, you should combine with the PK or do endoscopic vitrectomy, and so on and so forth. There is no end to the number of difficulties that we can face and we can expound and we can explain, but I guess the time is a limit. Thank you very much for your attention.